of respiratory tract infection. Okay, this is one of the important case for undergraduates. How to approach a case of upper respiratory tract infection or lower respiratory tract infection, which includes pneumonia and its complication. I invite Dr. A. Madhumita and S. Lokeshwari, the undergraduate students of the final MBBS from Arunai Medical College, to present this presentation on respiratory tract infection. Over to Dr. Madhumita.
Good morning. We are going to present a case on a respiratory tract infection. A 4-year, 4-month-old male child, Sharvin, from Tiruvannamalai, who was born out of a non-consanguineous marriage with order of birth 1. His informant was mother and reliability is fair. Was brought to the OPD by his mother with chief complaints of fever for 1 week, cough and cold for 2 days, and breathlessness for 2 days. The child was apparently normal before 1 week, after which he developed fever which was acute in onset, intermittent in nature. The child was not active during the interfebrile period. It was a high-grade fever and there was no diurnal variation. There was no aggravating factor and it was relieved on taking medication. The fever was associated with chills and rigors. There was no history of joint pain and rashes. It was not associated with loss of consciousness, lethargy, no history of convulsions.
Where is the presentation? Okay. So, on day 1, a child comes to you with fever. What is your thinking? Say the day 1, the same child comes to you with fever alone. Day 1, just few hours. How will you approach? The mother wants treatment for immediately because he wants to attend the nursery class, which is very, very important for the mother and child. Okay. So how will you approach?
We look for any danger signs.
Very good. So she will look for danger sign, red flag sign. Tell me the danger sign you will look in the child.
Whether there was loss of consciousness.
Very good.
Lethargy.
Very good.
Any convulsions present.
Very good. Why you want to ask about all these things?
Then the child is in severe.
Huh?
The severity is increased. It has to be referred.
No. What are the diseases which can produce lethargy, unconsciousness, convulsion, everything?
Encephalitis.
Any serious illness?
Encephalitis, meningitis.
Encephalitis, meningitis. Any not a serious, benign illness which also can produce day 1 fever and convulsion. Within few minutes, child become all right.
Febrile seizures, sir.
Simple febrile seizure. Don't say febrile seizure. Simple. What is simple febrile seizure?
It affects the whole body and lasts for less than 15 minutes.
So usually it's a generalized seizures.
Generalized tonic-clonic seizure.
Yeah.
Affecting whole body. It is not localized, affecting the specific part.
Okay, it is generalized seizure accepted.
It occurs only once in 24 hours, and there is no neurological deficit present.
Okay, no neurological deficit after the illness. Then? Usually, it occurs in there may be some family history of similar illness. The father may be having similar simple febrile seizures when they were children. Okay. Then it will be less than?
From 6 months to 5 years.
Yeah, 6 months to 5 years. Duration.
15 minutes, less than 15 minutes.
Less than 15 minutes. Okay. So these are so there is no CNS infection there. See, once the convulsion is over, the child may have some post-ictal sleepiness or drowsiness, then there is no neurological deficit at all. Child become normal. Okay, right. So what other danger sign? You said lethargy, unconsciousness, convulsion.
Whether the child is able to feed.
Taking feeds normally, very good. Any rash also a danger sign. Usually you call this child as whether the child is toxic or not. What do you mean by toxic?
Sick looking.
Toxic. Evidence of shock. Capillary refill time may be delayed. There may be, the child may be having altered sensorium. There may not be any eye contact with the mother. Mother will tell, sir, nam enne paakave maatengudhu. Child may be having severe respiratory distress. All those things you put it as a toxic child. Okay. So the child is toxic or not. Then usually you can see in IMNC it will say one thing is sicker. Sicker means what? தமிழ்ல சொல்லுவாங்க ரொம்ப முடியாம இருக்குது. Okay, ரொம்ப காயலா இருக்கு. That gives a lot of meaning. No mother will say ரொம்ப அது கொஞ்ச நேரம் மருந்து கொடுத்தா sick, become deteriorating, very sick child. So that also a danger sign. Okay, right. Then previous slide poma. So fever and cough. What is your thought? What are the causes of fever and cough?
Viral cause.
Viral. Okay. So multisystem child may be having fever as well as cough. Anything else? Upper respiratory infection. What are the causes of upper respiratory infection?
Bacterial.
Usually viruses, respiratory syncytial virus, rhinovirus, okay, adenovirus, all these viruses can produce. So what is the lower respiratory tract infection?
Pneumonia.
Pneumonia. So a child may have cough associated with fever, but in a pneumonia the cough will be minimal. Okay, usually viral infection you will have a severe cough, more likely to be viral illness. More, it's a science, nothing is 100%. Okay, so more severe cough, more likely to be viral. Minimal cough likely to be bacterial. Like pneumonia, you will not have a much cough. Except viral pneumonia, you will have a more cough as well as fever. Okay, next. Okay, high grade fever, diurnal, no joint pain, rashes associated, not associated loss of. Okay, next.
It was followed with a cough, which was insidious in onset, progressive in nature. There was history of wet cough, not associated with expectoration. No diurnal and postural variation. The cough is aggravated on exposure to cold environmental condition and not.
What is this child? So you have to tell whether the history, whether it's a wet cough or dry cough. What is wet cough? What is dry cough? Tamil என்னமா சொல்லுவாங்க?
சளி,
வறட்டு இருமல்,
சளி,
சளியோட இருமல், கல்லுன்னு இருமுதே. Okay, with sound in the chest. Okay, so when you will have dry cough, when you will have wet cough?
lower respiratory.
சத்தமா சொல்லுமா மைக் வச்சு.
Lower respiratory.
So lower respiratory, like pneumonia you will have a wet cough. Asthma you will have a wet cough. Which child will have a dry cough? You said lower LRI.
Upper respiratory.
URI you will not have wet cough, dry cough, varatirmal. Okay, and also you may have dog, barking dog. Adu enna cough? Tracheitis.
Groups.
Croup. Okay, gull. Okay, so some typical cough you can have. Okay, so history of wet cough, not associated with expectation. You don't expect even a 5-year-old, isn't it?
4 years.
4-year-old will not bring out sputum. Okay, it will, what will happen? It will swallow.
the sputum.
That's why you ask resting gastric juice for A, B, you put a tube in the empty stomach and take a sputum and see whether, that's why you take a sputum. The child cannot bring out sputum. If at all, you can do a saline nebulization and bring out sputum. Sometimes you can, little older child. Okay. Coffee, aggravated exposure to cold environmental, not relieved on taking medication. What does it mean?
Initially they
Huh?
So initially they took nebulization for.
No, you say exposure to cold. Cold, whether you get more cough. What does it mean? You want to tell something? Illamma, endha cough appadi jaasti agum cold.
Asthma.
Asthma, very good. Okay. Then, not relieved on taking medicine. What medicine she took? Not relieved.
They nebulized the child.
Nebulization didn't give relief. Okay. Cough was a running nose, watery in nature. So all cough usually, when they lie down, they get more cough. Okay, when the muscles are lax, usually way. But which cough will, when you lie down, naraya is a dry cough will have more. Which one?
Postnasal drip.
Very good.
Postnasal drip.
Postnasal drip. Okay. So it will go inside and child get irritated. Even we also cough, no? Postnasal drip. Okay, it's a dry cough. It is during lie down, it will increase. What is the postural variation? Where do you want to tell? When position, change in position, which cough?
Sir, in
Enna cough lamma, the postural variation, one posture the child will have more cough, the other side you will lie down. In bronchiectasis, so suppose the child is having bronchiectasis here, the affected side of the child lie down, no cough at all. The child lie down on the opposite side, the sputum will come here and irritate and the child will cough more. Okay, so it's a postural variation. Next, okay. Hoarseness of voice, you want to rule out some laryngitis, okay. No history of hemoptysis. Why do you want to ask that?
tuberculosis.
Tuberculosis. Any other condition you will get hemoptysis?
Bronchiectasis. Bronchiectasis.
Okay, not only respiratory cause, you have a established mitral stenosis also you will have because of the pulmonary edema, pulmonary congestion you can have hemoptysis. Okay. Post-tussive. Just any small child will vomit for everything, any infection, any fever. So don't give, okay, post-tussive vomiting is a typical diagnostic of pertussis. Okay, that pertussis cough is a prolonged cough. It will be for months together. Those days we used to call it 100 days cough. Okay, right. Not bilious, not blood stained. Okay, next.
Followed by cough, there was breathlessness which interrupted his sleep. It was acute in onset. History of chest retractions present and history of noisy breathing present. There was no history of chest pain, no history of bluish discoloration of lips and extremities. The cough and breathlessness increased in severity, for which he went to a private clinic and got better with nebulization, and it worsened 1 day later, for which he was admitted in AMCH. And
so what do you mean by that? Chest interaction, noisy breathing and all, what do you want to ask?
So lower respiration tract.
So probably you want to ask about, rule out asthma, isn't it? Okay. Chest pain, what are the causes of chest pain?
So
why do you want to ask chest pain in this child?
pleuritis.
Pleurisy. Pleural pain you can, what are the other causes?
Any
Chest pain, cardiac cause?
Pericarditis.
Very good. Then, cardiac cause of chest pain. Pericarditis. You can have mitral valve prolapse, you can have chest pain. Okay. Costochondritis, it's a non-cardiac chest pain. You will have one condition called alcoba, aberrant left coronary artery arising from right pulmonary artery. That condition mimic myocardial infarction. That also will have pulmonary embolism. You can have chest pain. Okay. Right? So, no history of bluish discoloration of. Why do you want to ask that?
Cyanosis.
Why? In this child?
Congenital heart diseases.
Congenital heart disease, respiratory illness. So you want to rule out any hypoxemia, respiratory failure, you can have a bluish discoloration, cyanosis. Okay.
Cough and breathlessness increased in severity, for which he went to a private clinic and he got better with nebulization. It again worsened 1 day later and he was admitted in AMCH, after which he developed abdominal pain. It was a dull aching pain felt in the upper quadrants.
Okay, so cough, breathlessness increased in severity. What do you think? Increased cough, increased breathlessness. What do you think it's due to? So breathlessness is due to? So the child was given nebulization, isn't it? Outside doctor, didn't improve. So what do you think? Suppose it is asthma, should have been improved. Now the child is not improved. What do you think?
Bronchitis.
Bronchitis.
Pneumonia. Sir.
Pneumonia. So the teaching is then primary health care, IMNC irukkalama. So if the child is having respiratory distress, you can, some wheezing also there, then you can nebulize and count the respiratory rate, whether the child is improved or not after half an hour. If it is improved, the child respiratory rate should have been come down, heart rate should have been come down. If it is not improving, then you can diagnose, maybe a case of pneumonia, you can give antibiotic. Improve with your bronchodilator, it's a case of asthma. You give bronchodilator, some steroid and send home. That is a primary care. So that's why I feel the child didn't improve. It's a known case of previous history of nebulization was there, everything. So we also thought in this child, initially we thought it is a asthma. Okay, next ma. So afterwards, why the child was having dull aching pain in the upper part of the abdomen? What do you think?
The lower lobe was involved, so the diaphragm gets...
Why lower lobe is involved in pneumonia, but the child is having upper abdominal pain?
Pain gets referred, sir, because the diaphragm...
So the same nerve also innervate the upper part of the abdomen, so it is a referred pain. So many lower pneumonia will have a severe abdominal pain. So don't fool by this sign. I have seen many pneumonias presenting as abdominal pain. Same thing, severe abdominal pain mimicking appendicitis. I have seen in dengue. Severe primary symptom. Okay. So, okay, next.
There was no history of close contact with TB patients.
Very good. So if there is somebody is taking very important history of contact with tuberculosis, you have to rule out. Okay, if there is nobody is there in the family not taking, how do you ask? How do you ask the history of contact with tuberculosis?
Hemoptysis.
Say anybody is having hemoptysis.
Drug, chronic cough.
IMNCL எவ்வளவு நாள் cough இருந்தாச்சுன்னா you got to refer. So chronic more than 14 days or more cough, you refer the child to rule out tuberculosis. Like that, if somebody is in the family having cough for prolonged period, யாருக்காவது வீட்டில் ரொம்ப நாள் இருமிக்கிட்டு இருக்காங்களா, இருமுனா ரத்தம் வருதா, recent death ஏதாவது இருக்குதா, some people may be having some infection. So it's true with HIV also, recent death. அம்மா அப்பா ரெண்டு பேருமே இறந்து போயிருப்பாங்க. They will not reveal. There is a social stigma is there. எனக்கு ஹெச்ஐவியில் இறந்து போயிட்டாங்க எங்கள் அம்மா அப்பான்னு சொன்னால் பெருமையாக இருக்குமா? இருக்காதே. அதனால தான். ஓகே.
There was no history of ear pain, ear discharge, no history of mouth breathing, no history of difficulty.
Why do you want to ask about mouth breathing?
Any obstruction in the nasal.
உட்கார்மா.
Any obstruction in the nasal passage, sir. Deviated nasal septum or
obstruction. Okay, மூக்கு அடைச்சிக்குது. வேற ஏதாவது? Adenoids. Adenoid hypertrophy, you will have a mouth breathing. Okay.
No history of
those days we used to see many adenoid hypertrophy with adenoid faces also, some broad mouth, something like that.
No history of difficulty in swallowing, no history of seizures.
Okay.
Past history. History of similar illness of cold, cough and fever was present 3 months back, for which he was treated with nebulization.
No, so similar illness, cough, cold, breathlessness was present 3 months back. Okay.
There's a history of recurrent respiratory tract infection.
So when will you call recurrent respiratory? I think I shared you in your group also yesterday. What is that?
For 3 to 6 years child.
இது வந்து எந்த வயசு? 3 to 6 years. Okay.
More than 5 episodes.
5 episodes. So because yesterday I was searching for what is recurrent respiratory tract infection. Then finally I got this from one article, whether it is reliable or not, because some Western book says if we require antibiotics, because we give antibiotics like anything. So this looks okay, 5 episodes per year, but it is very difficult to define. 5 episode அம்மாட்ட போய் இது வரைக்கும் 5 எபிசோடு வந்திருக்கான்னு கேட்க முடியுமா? அடிக்கடி சளி பிடிக்குது, இருமல் வருது, டாக்டர்கிட்ட போவோம், ஊசி போடுவோம், சரியாயிடும். ஓகே. ஸோ இட் இஸ் அண்ட் ஆல்சோ ஒன் மே பி நிமோனியா ஆர் 2 episodes of pneumonia.
Diagnosed clinical.
Maybe clinical pneumonia or X-ray pneumonia. Does it? இந்த மாதிரி இருக்கா இதில்? இருக்கு.
More than recurrent respiratory tract.
இல்லைம்மா. So this was the definition. You can, ஏன்னா அடிக்கடி இருமல் சளி எல்லா குழந்தைகளுக்குமே வரும். ஓகே. ஓகே.
There was history of seizures on day 2 after consumption of formula milk and was hospitalized.
The newborn period.
Yes, sir.
Okay, that may not be relevant now. Okay.
Then there is history of seizures following high fever was present, for which he was hospitalized and cured by medication.
Okay, previous history. At what age?
When he was 2 years.
So what do you think in this side?
Febrile.
So simple febrile seizure. You should be very specific, because simple febrile seizure doesn't require anything. No investigation, nothing. Although we do all the investigation, help people, ஒண்ணுமே தேவையில்லை. Just observe for any danger sign and send home with the counseling. Okay, the child may get till 5 years of age, all those things. Otherwise, it doesn't require. What first? Do you think you need a anticonvulsion prolonged therapy in this simple febrile seizures? No, not required. Okay, next. Next, Puma.
There was no history of congenital abnormalities, birth injuries, and no history of exanthematous fever.
Exanthematous fever means what?
For measles.
Huh?
For measles.
Measles, very good.
Treatment history. For previous episodes of similar illness, he was given nebulization with bronchodilators as treatment.
Okay, how do you know it is bronchodilator? Nebulization can be given by anything else you use for nebulization?
Oxygen.
Oxygen. Oxygen nebulize பண்ணி கொடுக்காங்க அத. ஒன்லி சால்புட்டமாலும் இதுவும் தான் கொடுக்குறம்மா. What else you give, ma? Nebulization? இப்ரோட்ரோப்பியும் கொடுக்குறங்க. அதுவும் ஆஸ்மாவுக்கு கொடுக்குறது தானே. விஸ்வா வாப்பா, இங்கே வா. மை ஃப்ரெண்ட். இப்போ 4 வருஷமாக எனக்கு தான் அவன் தான் பெஸ்ட் ஃப்ரெண்டு. ஓகே கம். வேறு இல்லைல்லப்பா நெபுலைஸ் பண்ணுவாங்க. இதெல்லாம் யூடியூப்பில் போகுது, எங்கேயோ இருந்து பார்ப்பாங்க. சுனிதா வில்லியம்ஸ் 3ல் இருந்து பார்த்துக்கிட்டு இருப்பா. பார்த்துக்கிட்டு யூ லைக் சுனிதா வில்லியம்ஸ்? வேண்டாமா? சரி சொல்லுப்பா. bronchodilator, salbutamol, levosalbutamol, all those things. அதான் ICS, ICS, inhaled corticosteroidsலாம் யூஸ் பண்ணலாம். anything else you use in a small child less than 1 year? இப்போ வார்டில் எவ்வளோ கேஸ் இருந்து ஒன்றுமே பார்க்காத மாதிரி இருக்கிறீங்க. ராஜஸ்ரீ hypertonic saline. அப்பா, so it is used left and right for என்ன கண்டிஷனுக்குமா நீ சொல்லு. hypertonic saline is used in asthma. Oh, நீ சொல்லு. bronchiolitis. So bronchiolitis treatment of choice is humidified oxygen number 1, then hypertonic saline, and also one more drug is used. அந்த உன் பேர் என்ன? நீ பேர் இப்போ சொல்லுப்பா. நிரஞ்சன் விஷாலா உன் பேர்? ஏதோ விஷால் இல்லை, ஏதோ விஷால் இருக்கட்டும், பரவாயில்ல. சொல்லுப்பா. Any other drug used in bronchiolitis? Inhaled, I mean nebulized. Which drug is used in emergencies? Anaphylaxis. Adrenaline is used. Okay. Although the questionable, the value of using adrenaline is, just listen. These are the questions they will be asking in the examination. Okay. Right. So you may not know whether, unless you know they have given a bronchodilator, usually it is bronchodilator. And also even other countries, they were used to give ribavirin nebulization. Rasmic adrenaline unde. Ribavirin also can be given as a, because in severe bronchiolitis, it is a, what virus might, respiratory syncytial, RSV. Okay, now the RSV vaccination also has come out in other countries. Hope in next few years we will also get it. Okay, next. birthலாம் விடுமா, அப்புறம் பார்த்துக்கலாம். எல்லாம் எழுதுங்கப்பா birth இதெல்லாம். So we don't have time. இப்போ இவர் வர. Okay. Next. இருக்கட்டும். Examination summary சொல்லிருமா. Next. So immunization, you have to be thorough with national immunization schedule as well as IAP immunization schedule. Okay. Any case they will ask whether you present cardiac, respiratory, CNS. So these are the basic things you should know. If you don't answer national immunization schedule, then there may be problem for you. I am telling you, these are the simple thing. Vitamin A prophylaxis, all those things will come here. National immunization schedule vandrum. Okay, next. So dietary intake, try to calculate. Nee daily சாப்பிட்றதுலே calculate பண்ணாலே போதும். Okay, but இவ என்ன போட்டிருக்க, protein deficit. Okay, is somewhere something wrong, because calorie deficit 500 வந்துட்டு protein வந்து 3 gram ரொம்ப லெஸ்ஸாக இருக்குது. Anyway, we are not going to that, because all our Indian diets are protein deficient. Calories will be very high. Okay, next. This was very important. Tell me.
Family history. There is a family history of bronchial asthma. It was a non-consanguineous marriage, and according to modified Kupuswamy scale, they belong to
Family history of family, who is having?
his mother is
Mother was asthmatic, he is on treatment. Okay.
according to modified Kupuswamy scale, they belong to upper middle class.
Next. So this is also important. Okay. Respiratory infection is very common among overcrowding families. Okay. Next. So as I told you, always write a small summaries. Start writing some summary. Okay. You can at the evening, 1 or 2 people can visit pediatric ward whenever there is a case, because 10-15 people crowd around the patient will run away. Even now we have one case of pneumonia. Okay. So pneumonia is the #1 killer now. Okay. Carry on.
A 4-year, 4-month-old male child who is developmentally normal and is immunized up to 9 to 12 months had initial complaints of fever for 1 week, cough and breathlessness for 2 days, and was treated with nebulization in a private clinic. It worsened 1 day later and admitted in AMCH. There is a family history of bronchial asthma. Child belongs to the upper middle class family according to modified Kupuswamy classification. He was born out of a non-consanguineous marriage. He consumes a diet with a calorie deficit of 515 kilocalories. And
no, but in a summary, you need not tell. If it is a nutrition case, you need to tell about all those things. Otherwise, with family history of bronchial asthma, okay, with fever, cough, cold, breathlessness, you have come to a conclusion probably.
Valerie, pneumonia or under 5 weeks.
Okay, so what is Valerie?
Wheeze associated lower respiratory tract.
When you say Valerie, because these terminologies are changing over the years. Nowadays we don't use Valerie. Those days you call it as asthmatic bronchitis. So it is, then they called it as wheeze associated LRI. The viral infection producing a wheeze, that's all. Now it is called virus induced wheeze. In a small child with hyperreactive airways, any viral infection will produce the bronchial constriction, because the bronchus level is size of the bronchus is very small, so it produces wheezing sound. Okay. So whenever the child starts with URI, any viral infection will produce wheeze. These children, so the treatment is same between asthma and a Valerie. You understand? Valerie, ennappa appadi potu kolapprangalanu nenikka koodadhu. Okay. So it is no diagnostic, but thing is, treatment is same, bronchodilator, steroid, everything. But these children, one group of children overgrow the tendency for wheeze. 4-5 வயசுல சரியாயிடும். Okay, but that non-atopic, non-atopic amma, the wheezer, okay, with with family history of wheeze and allergy, they will continue to have wheeze even after 5 years. Okay. So under 5 years, it is difficult to diagnose asthma because the child will not cooperate with pulmonary function test. Okay, it is a clinical diagnosis. Okay. So these children will always have a fever. Fever, மூக்கொழுகும் 2 நாள் இருக்கும், 3ஆவது நாள் going இழுக்க ஆரம்பிச்சிடும். But whereas asthma, you may not have fever. In science, nothing is 100%. Fever வந்திருக்கு, bees வருது, இது asthma கிடையாதுன்றது இல்லை. Okay, so she is right. Okay, but I don't know whether Nelson will still have some wheeze associated LRI. Is it given in Nelson? Valerie is. Okay. People sometimes they use Valerie, sometimes they call it as multi-trigger base. Don't confuse about all those things, okay? Right. Okay. So your first diagnosis, why you call this Valerie? Because child had fever,
Cough,
cough,
breathlessness, and
running nose, then
chest retractions.
good.
It's
Your
a under 5 child. And
previous history of asthma is there, okay? Then pneumonia. Why you thinking of pneumonia?
chest retractions, breathlessness.
Chest retraction, fast breathing, cough, fever, then upper abdominal pain is a referred pain. It's most likely. The only thing is the child was having severe cough. Most unlikely in a bacterial infection, severe cough. The child was having severe cough. Okay, still okay, but otherwise the child is fit into pneumonia. Okay, another thing is child not getting relief with bronchodilator. If it is a Valerie, the child would have been better with nebulization. Okay, next. So this under 5 is a broad term which your Valerie, virus induced use, asthma, everything will comes under that. Okay, so don't confuse about that, whether it is pneumonia or not, okay, whether it is asthma or not, okay. So the Valerie, முடிஞ்சா சொல்லுங்க Valerie-na என்னன்னா இது associated with viral infection, virus induced use. Nowadays you don't call it as wheeze, asthma or Valerie. Any virus producing wheeze is called viral induced wheeze. Previously it is called Valerie, asthmatic bronchitis, all those things. Okay, next.
General examination. On general examination, the child was conscious and oriented. The child respiratory rate was 46 breath per minute, and it's tachypneic, and the child looked as thin build. SpO2 saturation was 88%. So child was dyspneic, noisy breath presenting during examination. There is no pallor, icterus, cyanosis, clubbing, and edema, lymphadenopathy during examination. After getting consent from the mother and child, we exposed from head to toe. We start looking for head to toe examination. In head, the head's shape and size are normal. There is no deformity. And face, no dysformic faces. And eyeballs are normal. No bite at spots, no redness and conjunctivitis. Ear normal in position and shape. There is no abnormality and no discharge and pain.
What about other vitals? Pulse rate.
Sir, we are putting vitals are in
Yeah,
the slide.
later. Yeah, I can listen you talk. Okay. Okay. So you are going to explain later.
Sir.
SpO2 in which limb? This 88% was in which limb?
Right.
Yeah. Saturation was checked in which limb?
Sir, right upper limb.
Okay, so once you get a low value, you should check in all 4 limbs. And you should give 4 values.
Yes. Okay, sir.
Where do you get differential cyanosis? What are the conditions where you get differential cyanosis?
Cyanosis.
Differential.
Sir, congenital.
What is the definition of cyanosis?
Sir,
Definition of cyanosis?
sir, blue is discoloration of skin and mucous membranes.
It is due to?
Hypoxia or
That's what. So in this child, cyanosis is expected.
hypoxia due to
Says,
in oral cavity. There is no angular stomatitis.
Emma, what are the causes of clubbing? Please write, prepare, these are typical oral examination questions. Okay, clubbing, causes of clubbing, you tell me?
Infective endocarditis.
Respiratory causes.
Lung fibrosis,
Fibrosis
TB, bronchiectasis.
Suppurative lung disease. Number 1, bronchiectasis. pulmonary abscess சார் வந்துட்டாரா? கூப்பிட்டு உட்காரு. முன்னாடி அங்கே உட்காந்து. ஓகே, குயிக்மா. கிளப்பிங், வேற என்ன காசஸ் ஆஃப் கிளப்பிங்?
TB fibrosis.
எம்பைமாவில் கூட வரலாம், எம்பைமாவில் வரலாம். தென்
fibrotic stage of TB.
sarcoidosis, then
cystic
fibrosis, then all cyanotic heart disease will produce clubbing. Okay, right. So then how will you classify vitamin A deficiency? இல்லைம்மா, WHO classification என்ன? Madhumita, you can also help her. XN is XN night blindness, X1B, X1A conjunctival cirrhosis, X1B bite spot, then X2 corneal cirrhosis, X3A corneal ulcer less than 1/3, X2B corneal ulcer more than 1/3, then XS corneal scar, then XF xerophthalmia fundus. சரியா சொல்லணும்னா? சரி. Okay. Please read. Vitamin A, it will come in immunization schedule also. You have to read for the chat notes also. They will ask vitamin A, WHO classification. Right. Okay, this is all normal. Okay, lung, poma, respiratory, idukku po. Okay, next. Okay, next. Okay. Vapa, please come. We welcome Dr. Murali on behalf of our students. Ukar, and the chair important. Ukar. So tactile parameters is increase in the infraaxillary region. Ukar.
Inframammillary region and the infrascapular region of left side.
Okay, infrascapular region is also increased.
Infraaxillary and inframammillary region.
Next.
On percussion, there was impaired note here on inframammillary, infrascapular and infraaxillary regions in left side.
Okay.
On auscultation, vocal resonance are increased in inframammillary.
Crepitation is important. That added sound lalla varano.
Yes, sir.
So VFVR increased or decreased? That's what is the Sai Charana ambere? Yum perana? Gava. Sai version. In which condition you will get VFVR increased in some part of the lung? Asthma valla VFVR increase aguma?
Consolidation.
Pneumonia. It's a consolidation. Then you will, okay, you will have VFVR increased. Okay, then why you get that? You may have even, I don't know, you may have bronchial breathing also. It become thick, gray hepatization and red hepatization, then resolving. First is congestion. So it become thick, consolidation, no? Then you will have a bronchial breathing. All these signs, impaired note, all these things. Then when it is recovering, you will have the fine crepitations when resolving pneumonia. Okay. Next. So VR la varadu maadu. VR increased or decreased and solno. Okay. Added sound la dhaan adu solno. Next. So fine crepitation. Okay. So here
Fine
breath sounds are
representation.
heard, fine heard at the region of left lower lobe. So added sound ni potungo.
Yes,
Okay.
sir. On CVS examination, S1, S2 are heard. There is no murmur.
This is a case of Murali. It's a case of pneumonia. She is presenting. Okay. Next.
On abdominal examination, there is no tender and organomegaly. Abdomen is soft.
Oh.
CNS examination, no focal neurological
Very
deficit.
good.
Summary: the 4 years, 4-month-old male child who brought to OPD by his mother due to the complaints of fever for 1 week, cough for 2 days, breathlessness for 2 days. Examination revealed that there is subcostal retraction, no use of axillary muscle to respiration, and palpation, tactile premitters and vocal resonance are increased.
Always tactile premitters and vocal premitters will be same.
Vocal resonance.
Okay. Increased na VF increased.
In left lower lobe, and percussion, impaired sound heard in left lower lobe. Auscultation reveals the fine crepitations, so it's probable case of left lobar pneumonia.
Pneumonia. Okay. So your diagnosis is left lower lobe. Any differential diagnosis you like to offer? Only pneumonia.
Consolidation.
Okay. Sometimes it is a viral pneumonia or bacterial pneumonia? Bacterial pneumonia. Okay. We need not go into the details. So what are the, like you want to just clinical diagnosis is enough or you want to confirm the diagnosis? What are the investigation you want to do?
Sir, X-ray chest. X-ray chest.
X-ray chest. Good.
CBC.
TB screening for acute infection. CBC. Okay. What do you expect there?
Sir, leukocytosis may be present.
Leukocytosis. Very good.
Bacterial infection or
So usually it is associated with leukocytosis. May not be sometimes. Okay. Next.
to confirm that we CT chest we
So please, because we have the available CT, MRI available, we are also tend to take CT now. So don't tell it in the exam. I will do CT for, if she is telling CT, okay? No need of, do you agree with it?
It is usually not necessary, sir.
Not necessary.
Complicated expert opinion from the pulmonology, then only we'll do a CT.
Okay,
Otherwise,
even
not routine.
X-ray also sometimes not needed. It's a clinical diagnosis. You have a fast breathing, you have fever, your clinical evidence of fever, fast breathing, you can diagnose it as a pneumonia. You all know IMNC. Can you just tell IMNC classification, ma? Quick.
No pneumonia, pneumonia and severe pneumonia.
Yeah, no pneumonia, pneumonia, severe pneumonia. How will you?
When only cough and
How will you classify, ma? No, okay.
when only cough and cold is present, it's no pneumonia.
Okay.
In presence of chest retractions and fast breathing, pneumonia, and
Fast breathing. So previously chest retraction comes under severe pneumonia. Now fast breathing as well as chest retraction comes under pneumonia. If the child is able to take feeds, no cyanosis, nothing, then it comes under pneumonia. If there is a severe pneumonia,
danger signs are present.
okay, danger signs are not able to take feeds, cyanosis, hypoxemia, all those things, then severe pneumonia. Please read about this pneumonia classification. They will ask in the exams. So you will do, how will you treat this child? Oral antibiotic, very good. This comes under your pneumonia classification. So what antibiotic you give? Amoxicillin, very good. How much is the dose? 25. So now previously it was, we used to give 50 milligram and all. So now WHO says 90 milligram, okay, per kg. But in India it is not, even IAP says there is no need of high doses because our strep pneumonia it's a community acquired pneumonia, doesn't require any high doses. Okay, it is 40 milligram per kg is enough. There is usually you give it in double doses, 80 to 90. In other countries they are giving. They have found out some in Pakistan they did a study and found it is higher doses are necessary. India it is not necessary. Suppose the child not responding to your this one, what will you do? You give antibiotic, oral antibiotic.
IV antibiotics we try, sir.
IV antibiotic. Or you want to do something, child not improving after 2 days. What will you do, ma?
Any investigation to
Always the child may be going for some complications. Or your antibiotics may not be in correct doses, or your chosen antibiotic may be the drug of choice. Many people use some fancy antibiotic, cefixime. Okay, so what complication the child can go for?
pleural effusion,
Pleural effusion
Lung
or
abscess.
something else?
lung abscess.
Lung
pleural
abscess.
effusion,
Some pus in the pleura, you call it as?
Emphyema,
Empyema. Okay, empyema thoracis. So what is the organism?
staph,
Staph aureus. So how will you manage Staph aureus?
antibiotic,
Antibiotic, what antibiotic?
um,
Penicillin sensitive Staphylococcus aureus, what you will give?
methicillin,
Methicillin sensitive na enna kudupinga?
resistant, vancomycin resistant.
Penicillin. Cloxacillin is the drug of choice, but nowadays cloxacillin is not available. You can give augmentin also. Augmentin, coamoxiclav also, it acts against Staphylococcus. Okay. So suppose child is MRSA, not improving with the culture.
Vancomycin.
Vancomycin. So you may go for IV antibiotics like ceftriaxone and vancomycin. Ceftriaxone will cover the strep pneumonia and vancomycin will cover the MRSA. Okay. Any other antibiotics, staphylococcal drug of choice? Vancomycin. Anything else, ma? Need cholu, ma? Staphylococcal MRSA ganna. Raptomycin. Huh? Any antibody? Anybody? Huh? Linezolid. Okay. Clindamycin. Okay. Right? Okay, ma. How will you prevent pneumonia, ma? Huh? Prevention. பிறந்ததுலேருந்து ஆரம்பி பிறக்கும்போது என்ன சாப்பிட்றோம்? பிறக்கும்போது என்னமா சாப்பிட்றோம்? நம்ம இல்லை, குழந்தை என்ன சாப்பிடுது? Breastfeeding. So promote breastfeeding will prevent all infection. Okay. அதைத்தான் சொல்லணும் முதல்ல. எல்லாரும் சந்தோஷப்படும் சொல்லியிருக்கான். ஓகே, அப்புறம் ஸோ குட் நியூட்ரிஷன். தென் ஏமா ஒரு இன்ஃபெக்ஷனை ப்ரிவென்ட் பண்ணுறதுக்கு என்ன பண்ணுற? இப்போ
வேக்சினேஷன் சார்.
வேக்சின் கொடுக்கணும். என்ன வேக்சின்? நியூமோகாக்கல் கொடுக்கணும். வேற என்ன ஆன்டிபயோட்டிக்லாம்? அதில் என்ன ஆர்கானிசம் இருக்கு? ஒன்னே ஸ்டெப் நியூமோனியாவுக்கு நியூமோகாக்கல் கொடுத்துட்ற. வேற ஹெச் இன்ஃப்ளூயன்ஸா. ஓகே, பென்டாவேக் கொடுக்குறோம். டிபிடி, ஹெச் இன்ஃப்ளூயன்ஸா. பென்டாவேக்கில் ஹெப்படைட்டிஸ் பி இருக்கு, 5 இருக்கு. ஓகே, ஸோ ஹெச் இன்ஃப்ளூயன்ஸா. PCG also can produce, tuberculosis also can produce pneumonia. So you give PCG, so vaccine. Anything else?
Measles, sir, measles.
Measles. Very good. Anything else? Other than vaccine? Vaccine. COVID erpala enna pa pannum? So any infection, mask, hand wash. Okay, hand wash, frequent hand wash, using mask. Okay? Right. So good nutrition, prevention, hand wash, environmental hygiene, prevention of air pollution, all those things. That's a primordial prevention. நல்ல pure air இருக்கணுங்கிறதில்ல, அது நம்ம பண்ண முடியாது. Government has to do it. Okay. So anything else? Any doubt on that? So please read about, you can, I think I shared that IAP guidelines. Any topic on all these common topics, if you go to Google and put IAP guidelines, there are some 2-3 pages, it gives lot of treatment part of it, at least. I think I have shared it in your group also, isn't it? Pneumonia. Okay. So thank you for your excellent presentation. Okay. Thank you.
So morning all. So when you tell any investigation, always tell the first is the basic investigation, then you have to tell the specific investigation that has to follow. Majority of the kids here may have a comorbid like anemia, malnutrition. So you may have to take the CBC for all the child. Then you have to check for the CRP, C-reactive protein. Maybe peripherals may study if there is anemia is present. Then you have to say, I do a specific investigation. What investigation do? Chest X-ray, it is AP view or PUA view. Okay, for all pediatric, they cannot stand like adult population. We always do a AP view for the chest X-ray. So sir asked one question, is it a, what CBC is? Look for whether it is a lymphocyte or the polymorph predominant. If there is a polymorph predominant, most probably it is a viral. It is because sir asked, is it viral or bacteria? It is a lymphocyte predominant, you have to say most probably it is a viral pneumonia. If that you take a X-ray, lesion is extensive but less toxic, it is usually viral pneumonia. Okay, X-ray will be very extensive lesion, child will be less toxic. In bacteria, lesion will be very less but will be very toxic. There are exceptions also, like in COVID, even in flu, they will be very, very toxic. Then we will decide about X-ray, perialar infiltration. It comes the next category. But that what any investigation say, always go with basic investigation, specific. Suppose they ask, then what other modality if not improving? Then the commonly ask is a resting gastric juice. Because a 4-year-old child, they will ask, suppose she told, sir, I want to do sputum examination. The examiner will ask, how will you do sputum examination for a 4-year-old child? Every how will you do? So how will you do the resting gastric juice?
Sir, gastric lavage பண்ணி சரி ஆன்டிடியூப் போட்டு gastric lavage பண்ணி எடுத்துதான் சார் போட்டு ஏர்லி மார்னிங்கில் போட்டு
You have to take put a NG tube in the night time itself. So child when sleep, you should not awaken from the bed. It should be lied on the bed only. Even you should not baby assistant. The morning staff nurse or the doctor in charge by 5 o'clock or say even the child before awaken from the bed, you have to take the resting gastric juice. That is only the method of collecting the sample for sputum examination for CB nut. Okay, excellent, ma, very good. Thank you.
This child birth weight was 2.2 kg, was a UGR bound baby. Then there was protein gap, calorie gap. Then this is a 4-year-old child with a weight of 11.5, isn't it? So you should also talk about the comorbid conditions. This child was malnourished. Then you can also talk about the severity. Once a diagnosis is made, you give a differential diagnosis and capture the severity. Had interactions, no?
So as sir said, pediatrician always more interested on comorbidity than the direct diagnosis. Okay, usually we'll miss the anemia. That's why I told you. Anemia will be commonly missed. Koilanokia has been missed by even PG candidate to be failed. So next time only they have to reappear. The other one is a malnutrition. Since I told, you have to, in the diagnosis, you have to add the malnutrition status also.
So always don't forget about viral pneumonias. So you have lot of battery of investigation available. Biofire ne or 15-20 viruses, including H1N1. I mean this child we didn't give. Yeah. So it is little older child, you talk about walking pneumonia, atypical mycoplasma pneumonia, then you need to give azithromycin. Suppose it is a H1N1, what will you give? H1N1 என்ன அம்மா கொடுப்பீங்க, என்ன antiviral?
What antiviral?
Huh? என்னம்மா?
Zanamivir and oseltamivir.
So nowadays, I think the other day also I shared some investigation, I mean some incidents. Now of more incidents of viral, okay, more than bacterial. It's like a developed country. Okay, thank you, Pa. Thank you.